Okay, it's 3 p.m. and we have reached 30 attendees. So we can start, Dr. Vijay.
Okay, great. Yes, so good evening, everyone. Thank you to everyone in attendance today. Welcome to our College of Physicians weekly webinar. As we all know, the month of May is the month of hematology, and this is currently our second week. With us today, we have got two distinguished people, Dr. Lim Soo Min and Dr. Bu Yang Liang, both from Hospital Sultanah Aminah in Johor Bahru. Our topic today will be titled Myelomas and also Paraproteinemias. All right, so do allow me to introduce Dr. Lim Soo Min, our chairperson for today. It is personally my greatest pleasure and honor to be able to introduce Dr. Lim. He is a consultant hematologist in Hospital Sultanah Aminah Johor Bahru, a very humble person who did not share his CV with us. I think this has happened during the past few times when we invited him for talks as well. But basically what I can say is that he's a national trainer for hematology, and he has trained many young and budding hematologists. And I think that he is actually an inspiration to many of us when we were in Johor Bahru. Take it from me as well. Okay, so it gives me pleasure to introduce Dr. Lim Soo Min. Dr. Lim, the floor is yours.
Thank you very much, Dr. Ko, for the kind introduction. It's my pleasure to introduce Dr. Bu Yan Liang, who is my colleague at HSA, who is currently a consultant hematologist as well as a physician at HSA. So Dr. Bu graduated in 2009 and subsequently obtained his MRCP in 2013 and went on to do a training in clinical hematology and completed his training in 2021. During his training, he also spent a year doing transplant as well as advanced hematology training in NUH Singapore. He is a very knowledgeable and dedicated hematology, and it's my great pleasure to have him deliver the talk for today. So please welcome Dr. Bu.
Thank you, Dr. Lim. I need a little bit of adjustment on the topic because this is mainly for our physician as well as medical officers. So today I'm going to talk about multiple myeloma and what a non-hematologist should know, so that whenever the pre-referral workup can be done in a timely manner as well as before referral to us. So without further ado, let us just start our talk today. So I get one of these article from Clinical Medicine. Clinical Medicine is actually our Royal College of Physicians. So they have a CME previously, I think last year, talking about myeloma, what a non-hematologist should know. I think this is a good article that all of you should try to look up on this and have a read through. It's only 3 pages. So let us start our topic with a case presentation. So a 66-year-old man with underlying hypertension, autoimmune vasculitis on immunosuppressant, prior to this on PrEP as well as mycophenolate, was referred for persistent high globulin and ESR during his follow-up by a rheumatologist for the past 2 years. Otherwise, he's asymptomatic. From this clinical presentation, although the history is a little bit short, what should you proceed from here? So a second case, another 68-year-old man presented with a bony pain over his ribs for the past 2 months and associated with loss of weight. He was admitted to a private hospital and noted to have mild renal impairment, raised globulin, and subsequently referred to us for further management. So in this particular case, how should we investigate further? So from these 2 cases, I hope that later we can try to delineate or outline the mode of the investigation that is required and will be beneficial for this group of patients. So most of the time when we saw patients, other than presented with typical symptoms of myeloma or paraproteinemia, that might be some subtle clue that make us suspicious of multiple myeloma or why we want to investigate further for plasma cell dyscrasia. So one of the common causes are raised globulin, and reverse AG ratio. So just to list out a few causes for raised globulin. So infection is one of them, like chronic bacteria, tuberculosis, viral infections, inflammatory disorders, for example, autoimmune disease, SLE, immune disorder, rheumatoid arthritis, as well as malignancy, myeloma, lymphoma, etc. So bear in mind that any raised globulin may make you suspicious of multiple myeloma or plasma cell dyscrasia, but it may not be necessary to be myeloma. So we always have to exclude other more common conditions, for example, inflammation, infections, or immune disorder concurrent before we came to a possibility of plasma cell dyscrasia. So in that case, when do you suspect plasma cell dyscrasia? In a patient with raised globulin, when referred to us, we look into patient symptoms. Okay, for example, any bone pain, any anemic symptoms, any renal impairment. Okay, all these might actually help us to think of the higher possibility of plasma cell dyscrasia. Hypercalcemia, of course, the symptom of hypercalcemia, for example, bone pain, abdominal discomfort, constipation, all these may happen at the same time. So with the presence of symptoms and raised globulin, this further increase the probability of having plasma cell dyscrasia. So what should be done next? Routinely, a few investigations that is available in district hospitals as well as most of the centers include full blood count, which shows most of the time are anemic, or sometimes may due to diffuse infiltration that cause more worsening of cytopenia that include platelet and white cells. Renal function test, where renal impairment is one of the end organ manifestation of myeloma. Calcium level, which include hypercalcemia. Peripheral blood film, which usually shows some rouleau formation due to the high globulin level, stack out of red cells. Serum paraprotein electrophoresis, serum free light chain, and apparently nowadays in our center, we still have to send for urine paraprotein electrophoresis as a surrogate test for serum paraprotein electrophoresis. Otherwise, most of the time, the test will get rejected, as well as imaging study. So what is rouleau formation? So rouleau formation, myeloma is just one of the possible cause of rouleau formation. Any form of raised globulin will cause rouleau formation, and this can be due to inflammatory condition, and it can be due to polyclonal immunoglobulin. Plasma cell neoplasm, of course, and sometimes you may see actually in cases of pregnancy due to increased fibrinogen concentration. Renal impairment is very common. Up to 20% of the patient may have raised serum creatinine upon diagnosis of myeloma. Some may even have severe enough that requiring dialysis at the point of presentation. And the most important cause are due to cast nephropathy, which we refer as myeloma kidney. And sometimes we may have glomerular deposition of immunoglobulin, or light chain amyloidosis, or immunoglobulin, which is immunoglobulin deposition disease. In these type of cases, if systemic involvement is not manifested, for example, by doing a bone marrow, there isn't any plasma cells, and the immunoglobulin deposition mainly at the kidney, we may refer these type of cases as the MRGS. Okay, so the diagnosis can only be made by doing a renal biopsy. SPEP and SFLC is part of the investigations that required whenever we suspect myeloma. Bear in mind, in our center in Malaysia, most of our center in Malaysia, our serum paraprotein electrophoresis can only be back in 6-week time. So we should not really wait for our SPEP in order to make the diagnosis or increase suspicious of myeloma. Rather than if, let's say, is clinically suspicious, we should always proceed with a bone marrow aspiration and trephine biopsy. So just a few slides on what is SPEP. Yeah, sure. So before we talk about SPEP and SFLC, we should know the normal configurations of immunoglobulin. So as illustrated in this slide, this is the normal immunoglobulin structure where we do have heavy chain as well as light chain. If you still remember our immunology, our heavy chain can be made of IgG, IgM, IgD, IgA, and IgE. So our light chain can have kappa and lambda. So why is polyclonal and why is monoclonal immunoglobulin? Because this will affect how we interpret the test and how we read the SPP. Based on how you interpret the test, you will actually eventually consult us, because whenever there is polyclonal immunoglobulin, there will be a monoclone that actually produced by that producing the immunoglobulin. But once it's a polyclonal, most of the time it's due to a different clone, and this likely associated with inflammation, infections, and it may not be related to plasma cell discretion. So polyclonal immunoglobulin is produced by different plasma cells. So in myeloma, it's different because myeloma came from the same clone, and they should produce a similar clone of immunoglobulin as what illustrated in this diagram. So what is SPP? SPP is, in long name, is called serum paraprotein electrophoresis. And whenever they do a SPP, you can actually see a spike, different spike of protein that we can see from the graph. So albumin will be the highest in our body, in our serum, then followed by alpha 1, alpha 2, beta, and gamma region. So most of our immunoglobulin are actually within this gamma region, but some of them, like IgA, IgM, may spill through into the beta region. So whenever the test that has been, the report from the test, they actually interpreted for us already. So, but it's good that we know what are actually different proteins within what are these regions, so that when we interpret the test, we can actually look into the other possibility. These just some of the protein that we can see in different regions of the protein electrophoresis, and the gamma region is the main one that of interest in multiple myeloma, as what we saw in this spike. So whenever we saw there is a monoclonal globulin that within this gamma region spike, as what seen in this diagram, we will proceed with serum immunofixation. What does serum immunofixation do is that it will tell us what type of immunoglobulin are we dealing with. So this is what we saw, the M band, that spike that we can see, and then this is what immunofixation all about, where actually there's a IgG, anti-IgG, anti-IgA, anti-IgM, anti-kappa, and anti-lambda. So whenever there's an abnormal monoclonal protein, there will be a similar pattern that we are going to observe. So in this case, it's an IgG kappa. So in this case, it's an IgG kappa as well. So this is what we actually saw from the immunofixation. Of course, in the report, it's not being mentioned. I will let you all have a look at the report later. So paraprotein means it's a monoclonal protein. So beside myeloma, we still can see paraproteinemia in other causes. For example, in lymphoma, in especially in Waldenström macroglobulinemia, we can see actually it's IgM, IgM globulin. CLL, sometimes we can see cryoglobulinemia, POEM syndrome, AL amyloidosis. AL amyloidosis, sometimes we can more of a light chains disease that either kappa or lambda that we can observe. So a lot of times from district hospital, when referred to us, serum free light chain was not being sent. At this age, I think serum free light chain is a very important test, where serum free light chain are actually the light chains that is being accessed, and is beyond the detection of SPP. That's why the serum free light chain is important for us to look into which is predominant, whether it's a kappa or lambda. So this test has actually replaced urine paraprotein electrophoresis. If we look into urine paraprotein electrophoresis, the main things that we are looking at is Ben-Jones protein. Ben-Jones protein is another name for serum free light, the light chain. So this has greatly replaced UPEP in the process of myeloma diagnosis. So except for primary amyloid, based on this international myeloma working group recommendation, other than this, I think UPEP is not a must test that we have to send. Unfortunately, I think if we send an SPP without UPEP, it will get rejected. So in the end, I think UPEP was a routine test that being sent as a surrogate together with the SPP nowadays. So imaging, conventionally we did skeletal survey, but skeletal survey, although is widely available in most of our hospital and is one of the most accessible and cheap type of investigation, is low sensitivity, whereas at least 30% of the bone substance loss must be happen before the detection via skeletal survey, and there is a low specificity whenever you see in certain area where there is obscured by the bowel. So in most of our center, I think we still go for skeletal survey. So if highly suspicious of myeloma, please do a skeletal survey, get the reporting done, or at least attach the X-rays for us to review. Otherwise, this group of patients may not have a baseline bone assessments, and during the follow-up, when we look into the response assessments, we can't really make a comparison pre and post treatment. So if let's say there is an option, I would always go for a low dose whole body CT scan. Unfortunately, I try to, even in JB, most of the private center do not really conduct a whole body CT scan of low dose low radiation dose. PET-CT is widely available nowadays and is relatively quite affordable as compared to as comparative to CT scan and MRI. So these three are actually quite suggested if, let's say, we are going to proceed with any imaging study other than skeletal survey. So this is the skeletal survey. In this skull X-ray, you can actually show multiple lytic lesions seen, and in this pelvic X-ray, actually we can saw some lytic lesions seen over the pelvic as well as the large axial skeleton. This is a PET scan. So this is a pre-treatment PET scan, and this is a post-treatment PET scan. So if, let's say, we have a pre-treatment assessments using a PET scan, it's good that after treatment we should always do a post-assessment. However, due to the availability of tests or imaging studies as well as the cost, a lot of time patients may have a pre-assessment if they can afford, but post-assessment sometimes they might not have. So next, we should always proceed with a bone marrow aspiration and trephine biopsy, and samples should be always sent for immunophenotyping, especially looking into myeloma cells. Cytogenetics, because I'm going to elaborate further why cytogenetics is important in current era of treatment for myeloma, and FISH study for myeloma panel. And these tests actually in JV we do routinely send to Hospital Kuala Lumpur, and they give us a very good result for both cytogenetic and FISH study. And it's very beneficial for us to prognosticate this group of patients and to intensify the treatment or maintenance later. So this is just two diagrams that what we saw from our bone marrow aspirate looking at these abnormal plasma cells. Typical plasma cells should not be such a bizarre looking binucleated cells. Okay, so as I mentioned, why nowadays we do send for FISH and cytogenetics is because of the prognostication. Previously, we don't do that because of the availability of tests. But at this era, I think doing cytogenetic and FISH no longer some high-end tests. So we should routinely send in order for us to prognosticate and guide our treatment. And with the availability of treatment for myeloma, I think doing these tests are even bring more meaning for the patient. So Just good to know, having a cytogenetic of hyperdiploid, which is rather common, usually give a better outcome. Okay, and it's actually a standard risk. No doubt, this group of patients actually have a better outcome. Certain translocation, for example, cyclin D1, cyclin D3, 414, 1416, 1420, all these are actually can't really be detected using a conventional cytogenetic. So FISH study will be important. And certain translocation actually give a different prognostication for this, our myeloma patient. So let's come to the diagnostic criteria. In the end, if let's say patient got symptoms after all these tests has been done, then we have to properly see whether which group of patient actually, whether this patient actually fulfill the diagnostic criteria for myeloma. So typically, I think all of us should know about CRAC. CRAC means calcium, renal involvement, anemia, as well as bone lesion. Lytic bone lesion. So in 2014, I think there's a revised international myeloma working group for myeloma as well as smoldering myeloma, as in addition to all these plasma cell leukemia. So they included another 3 criteria, which has a high risk of progression to symptomatic myeloma. So what we call as nowadays we go for slim CRAC criteria in the diagnosis of multiple myeloma. Slim S for 60% of more than 60% of plasma cell. Li means involved, uninvolved serum free light chain of more than 100, and M means MRI scan show more than 1 focal lesion. So smoldering myeloma means those that do not fulfill myeloma, but have a serum paraprotein IgA or IgM of more than 30 grams per liter, or urinary monoclonal protein more than 500 milligrams over 24 hours, as well as clonal bone marrow plasma cell 10 to 60%. So these are the other diagnoses that possible can be made based on the presence of paraprotein. It can be a monoclonal gammopathy of undetermined significant, MGUS. It can be a smoldering myeloma or plasma cell leukemia. This is just to highlight that previously, in the previous edition of plasma cell leukemia, 20% was quoted as the presence of plasma cell from peripheral blood smear. But nowadays, they bring down the plasma cells level to 5%. So it's a routine that we should always send for peripheral blood films in order to access for presence of plasma cells, abnormal plasma cell within the peripheral blood film, in order to make this plasma cell leukemia. And this brings a very, very poor prognosis. So for staging system per se, there's a few things that we are looking into: the host characteristic, the cytogenetic abnormalities, response to treatment, as well as especially during the induction treatment, as well as the tumor burden. So the staging in myeloma is rather different from what we routinely see for other malignancy, for example, breast cancer, lymphoma, or lung cancer, where the staging mainly is for prognostication. So previously, the Duria staging has not, is already being out. We are not using that anymore. So nowadays, we are going for international staging system where serum beta-2 microglobulin as well as serum albumin was being set, and the revised systems actually incorporate cytogenetic as well as FISH study, including LDH. So typically, I will actually hope that we do routinely send for beta-2 microglobulin, albumin, as well as LDH, because in our center here, whenever we receive cases from other district hospital, we do not have all this information for us to properly stage our myeloma patient. And as we can see, different stages give rise to different overall survival as well as the median progression-free survival. The higher the stage, the worse the outcome. And let's back to case 1. So if you remember, the case 1 actually showed just some underlying autoimmune disease with raised globulin and ESRs, therefore refer us for further management. So the hemoglobin was 12.8, calcium was not high, creatinine was normal, albumin is not too low, it's just at the verge. beta-2 microglobulin is not raised as well. So when we did a serum free light chain, actually show a kappa light chain restrict, kappa light chain predominant, and the ratio is 11.203, which is raised. Then when we look into the paraprotein, you can see that the paraprotein is actually 58.31 gram per liter. And when they look into the immunofixation, it's actually a IgG kappa paraprotein. And there's presence of immune paresis. So whenever patient got immune paresis, the important thing is that the patient is actually at a higher risk of infection. So the paraprotein that being produced, or the immunoglobulin that being produced by the patients, is actually non-functional, and therefore patient has a higher risk of infection. And as a surrogate investigation, they do a urine paraprotein electrophoresis, which is consistent with kappa light chain paraprotein urea. So this patient was lucky that he actually self-funding doing a PET CT and show a focus on mild increased FBG tracer accumulation in the left axilla as well as the ribs, which is so small, but at least it's more than 5 millimeter, which is more than what is being mentioned in the diagnostic criteria. But it's only one. So we actually further doing a bone marrow shows 15% plasma cells, which is abnormal. And Trifine is also consistent with there's an increase in abnormal plasma cells, positive for the myeloma cells marker. And IPT consistent with that. And FISH study actually negative for TP53 and all the translocation. So he was diagnosed with smoldering multiple myeloma, where he actually fulfilled the criteria. And in smoldering myeloma, we don't really use these ISS or RISS. We use a Mayer's risk stratification, which include 2020. So for him, it's actually a low to intermediate risk. So back to case 2, which patient have symptoms of bone pain. So further investigation actually showed normal hemoglobin, the calcium is not raised, the renal impairment is mild, but it doesn't really fulfill the criteria of 177 micromole per liter. Albumin is not low, our beta-2 microglobulin is not raised, LDH is normal. So he also did a PET scan which showed some expansile soft tissue mass at the vertebral body, which consistent with why he having all these bone pain. And there's also some FDG avid lesion over the sternum and other spinal bodies. So did a MRI spine because of all these lesions. So the MRI actually showed multiple lytic enhancing lesion involving the whole spine, ribs and iliac bones. So clearly this is actually got a symptom bone. So let's look into the aspirate. So the bone marrow aspirate actually show 40% plasma cell, and the Trifines actually have a higher numbers of higher percentage of abnormal plasma cell, up to 60%. And IPT actually show a clonal disease. So SPEP eventually come back to have a 45.2 gram per liter of IgG kappa with marked immune paresis. And the FFLC actually can't really tell us a lot. Is mainly of normal ratio, but that eventually we can't really use FFLC to monitor the response. So we have to depend on the SPP. So the cytogenetic show no cytogenetic abnormality detected, which is this a normal cytogenetic for a male. And the FISH study for high risk translocation show no IgH, FGFR3, IgM, MAFT is a 414, this is a 1416, and there's no loss of TP53 signal, which is a 70p deletion. So this patient was diagnosed with multiple myeloma. The myeloma defining event is lytic bone lesion, and the revised ISS risk stratification is stage 1. So both of them actually, eventually the first patient actually progressed after 1 year of monitoring into a full-blown myeloma with bone pain, and the repeated MRIs actually show some lytic lesion and a specific spinal lesion, and he responded very well to our induction therapy as well as the subsequent transplantation. So the second patient actually is in the middle of induction therapy. So the management of myeloma is at this stage is still a treatable disease but incurable disease. So it's more of a chronic disease rather than it can be cured eventually, but we never know. Possible in 5 to 10 years time, it may be a curable disease. So the timeline of medication development is rather interesting. So prior to that, steroid has been the backbone of myeloma treatment. So any patient with myeloma, steroid. So in the 90s, when melphalan has been used widely, melphalan steroid has been the main treatment of choice until end of 1990s, where thalidomide has been found to have myeloma activities. If we remember thalidomide is the medication that used for morning sickness in pregnant lady in the 60s, where it actually caused a lot of teratogenicity, and a lot of children born with absent limbs, and thus was withdrawn from market. Eventually, it was found to have anti-myeloma activities, and thus melphalan, thalidomide, dexamethasone has been the mainstay of treatment in addition to our conventional chemotherapy. However, after 2020s, after 2000s, there is actually robust new medications that is being found to have anti-myeloma activities, and these include proteasome inhibitor, where bortezomib is our first generation, and we have our second generation of carfilzomib, and after that we have our oral medications of isazomib. Immunomodulatory drugs, where thalidomide is our first generation, lenalidomide is our second generation, and pomalidomide is our third generation. Of course, we do have some monoclonal antibodies, anti-CD38 antibodies like daratumumab, elotuzumab. Okay, we do have our isatuzumab, isatuzumab, some form of monoclonal antibody as well. And we do have our bispecific antibodies or antibody drug conjugate, for example, blinatamab, mofodotin, that is still not available in our country. So at this stage, I think those medications that are available in our country include Velcade, which is widely available, lenalidomide, pomalidomide is available, daratumumab is available, and isazomib. The rest are still not available in our country. And CAR-T has been used in myeloma using a BCMA, which is one of the markers in myeloma cells, and it is no doubt is very costly, but it's somewhere that cellular therapy is going into our era soon. So as we can see, with the robust treatment that are available nowadays, the outcome, the survival of myeloma has been improved. And nowadays, the median survival for myeloma patient has been extended. For those standard risks, it can go up to 8 to 10 years as compared to less than 5 years previously. So just a brief approach. I don't think you all need to know in detail what type of how we're going to treat myeloma, but at least we know the how we actually approach in treatment of newly diagnosed myeloma. So whenever we saw a patient with come to us newly diagnosed with myeloma, the first thing that we ask ourselves is whether this patient is transplant eligible or transplant ineligible. In the patient who are transplant eligible, then we will bear in mind that we will always think of having this patient to have stem cell collected, and subsequently we may plan for this patient to go for autologous stem cell transplant. So based on the stratifications of prognostication of risk stratification, we divided this group of patients into whether it's a standard risk or high risk. High risk will include those high risk of cytogenetic high risk patient. And in overseas, VRD has been the standard of care, where V stand for bortezomib, which is a proteasome inhibitor, lenalidomide, and dexamethasone. These are triplet, what we call. Triplet is always better than doublet and always better than a single treatment therapy. So in our country where lenalidomide is still rather costly, most of our center actually use thalidomide in replace to lenalidomide. So if you ever saw a patient with myeloma in your hospital, you can always see what is actually VTD. VTD is actually Velcade, which is bortezomib, thalidomide, and dexamethasone. C, cyclophosphamide, is an alkylating agent. So we do use these two agents to replace VRD in most of our patients. So we do collect patients after collect their stem cells, and we cryopreserve them. In those who go for stem cells transplant, we usually do it after 6 cycles, because the date that we have to collect stem cells and eventually plan for autologous transplant is almost like 6 months and beyond. So after transplant, we do routinely go for some IMiD maintenance, which is either lenalidomide or thalidomide, both are feasible. So in high-risk patient, we don't have DARA. So most of our patients, again, they actually go for the same treatment, and they go for early stem cell transplant, and we do routinely go for at least thalidomide maintenance. Of course, in center or if patient can afford, these are the best, but we have to tailor with our own setting whenever we treat patients with myeloma. So in those who can't really go for transplant, so these are what we are actually go for. Standard risk, we go for same thing, VRD, VCD, VTD, both are feasible. And then we go for maintenance. Or after that, we can go for thalidomide maintenance, same thing. Okay, no much of difference. Of course, when relapse, we tend to also use 2 or 3 medications, but that is beyond the scope of the talk today. So I think these are more relevant to you all. Whenever you saw a patient with myeloma, before diagnosis, during diagnosis, or during treatment, I think infection is the main reason why patients eventually succumb to death, besides relapse or refractory disease. So patients have increased risk of bacterial infection or viral infections. And in patients who are on bortezomib, they are actually at a higher risk of herpes zoster reactivation. So all patients must on acyclovir prophylaxis. And whenever they get herpes reactivation, sometimes can be very, very severe. And these can be due to myeloma as well as patient comorbidities, including prolonged high-dose steroid, and all these can actually affect the body immune system. So we don't routinely practice antibiotic prophylaxis. Of course, there's a trial looking into whether using antibiotic prophylaxis for the first 12 weeks of treatment using a levofloxacin, which shows there's a markedly reduced febrile episodes in this group of patients. IVIG, we do give in patients who actually admitted for sepsis. Vaccination, those inactivated vaccine can be actually given, but I would suggest to give possible after treatment or whenever patient on maintenance, because it may actually affect the efficacy of vaccination. Bone disease, most of the patients have bone lesion, and routinely we do give bisphosphonate like Zometa. Zometa is our what you call zoledronic acid, okay, and denosumab, which is our rank ligand inhibitor. So just bear in mind, in patients who are started on bisphosphonate or denosumab, we should always do a dental clearance, because there's a risk of osteonecrosis of the jaw. And this can be very causing a lot of morbidity for this group of patients. So if possible, doing a dental clearance before referral to us, that would be much more appreciated. Peripheral neuropathy can happen, especially in patients on bortezomib as well as thalidomide. And this usually can be quite difficult for the patient. Thromboembolic and cardiovascular, especially in the combinations of IMiDs plus high-dose dexamethasone. So aspirin and anticoagulation may be part of the treatment, and we routinely give this group of patients antiplatelet as well as anticoagulation. And renal disease, in patients who come to us before the diagnosis and in patient with especially in patient with hypercalcemia. Importantly, you all should hydrate properly, treat the hypercalcemia, avoid nephrotoxic, and refer to nephro colleague for dialysis support whenever feasible. We do see some patients who actually have renal impairment, but just improper treatment or hydration given, and these patients have eventually developed into end-stage renal disease. So those reversible should be treated appropriately or promptly whenever patient landed in your hospital. So in summary, I think I would say that recognizing the clinical feature of plasma cell dyscrasia and correlate with the initial lab investigations are very important, because some of the patients are being delayed up to a few months before the diagnosis of myeloma being made. So in patients who have possible complications from myeloma, please support as soon as possible. And in patients who are on anti-myeloma treatment landed in the hospital due to infection, please do call us up. We are happy to help out. However, do not wait for us to tell you what to do. In infection, just treat first and let us know, see what we can actually improve on the management part. Essential investigation for diagnosis and prognostication, risk stratification is important for us to decide on the long-term management outcome. I did a summary slide for the investigation to be carried out for patients with plasma cell dyscrasia. So I think all these tests are available in Malaysia. So I don't see any reason why these tests are not being sent, especially when patient was being already referred to us for myeloma, and tests are still not being done, and patient when come to us, we have to dig back whether all these tests are being sent from the respective hospital or not. So importantly, full blood count, full blood picture, liver function test, as mentioned, albumin, LDH, important for ISS, renal profile, calcium level, STP, SFLC, beta-2 microglobulin, marrow, IPT, cytogenetic FISH for myeloma panel, as well as imaging, at least skeletal survey. But in patients who can afford, of course, clinically indicated with very bad spinal involvement or neurological involvement, MRI spine is indicated. I think that's all from me. Thank you.
Thank you, Dr. Pu, for an excellent talk on multiple myeloma. I have to say, I really enjoy listening to your talk, and I think it's so relevant to all the physicians out there in the district hospital that Dr. Pu has told us what are the important investigations that we must do prior to refer to a hematology center for investigation. And that really includes, I mean, the usual test that everyone will send, we won't miss out on that. But more often is we get a patient that don't have a beta-2 microglobulin, don't have LDH, and when perform the bone marrow, there was no cytogenetic or FISH study sent, and it's so difficult for us to even convince the patient to repeat the test again. So please bear in mind that these tests are really important, as we have made a lot of progress, as what has been shown by Dr. Pu. The risk prognostication is so important now. He also showed to us that because this patient have a very long-standing treatment, unlike leukemia, the treatment may be just a few months, but multiple myeloma, they are relapsing in remission for many years. So this patient, they may see hematology center every 1 month or every 2 months, but they will follow up with the district hospital more often. And so it's very important to recognize all the complications that can arise from the disease as well as the treatment. One thing that we notice is that quite often the diagnosis was made rather late because people never really thought of multiple myeloma. Dr. Pu, what do you think? Anything we can do to to sort of like make a earlier diagnosis for multiple myeloma?
I think more of like higher suspicious of myeloma in patients, especially in patients presented with symptoms. A lot of times, I think this group of patients are being admitted to our orthopedic colleague, orthopedic department, and being seen by our orthopedic colleague. Without those hypercalcemia, most of the time they don't refer to us until unless they saw some suspicious lytic lesion. And then a lot of times, concurrently, they will treat for TB, tuberculosis, empirically, and without thinking of myeloma. So I would think that if they ever refer to our physician colleague, we should always advise possible for biopsy, or at least for a simple blood test like our full blood picture to look for any raised globulin or increase our suspicion of multiple myeloma. Eventually, if other things are normal, they should not treat empirical for tuberculosis. But we do have a few patients who turn out to be a multiple myeloma or plasmacytoma whenever we did a biopsy eventually, where patient already there's a delay of at least 1 to 2 months due to the anti-TB treatment. Our suggestion will make a difference for our colleague, our orthopedic colleague, to take a different view on what the other possibilities that can happen in this group of patients.
Yeah, thank you, Dr. Wu. I think over the years, those housemen that have come to do a 2 weeks posting in Hemato, they know pretty well about multiple myeloma, and then when they go on and work in orthopedic or other unit, they actually help to raise the possibility of this multiple myeloma when they see these patients. So we see some improvement over the years. Just to add on to what Dr. Bu said also, don't take a normal globulin as to rule out multiple myeloma. As you know, about 15-20% is light chain myeloma, so you may not get a raised globulin. And also don't take absence of lytic lesion as not multiple myeloma, because using just X-ray skeletal survey, we can only pick up about 50 to 60% of the lytic lesion. So in summary, it's just that we should have low threshold to think of multiple myeloma, and when things are unsure, either call us up or arrange for a bone marrow examination. We also have some questions in the QA. First one is what criteria to initiate myeloma treatment in smoldering multiple myeloma?
Okay, so I think there is at least 2 trials that look into this smoldering myeloma, and both trials actually started treatment for those high-risk myeloma. As I mentioned, the Mayer classification, you can actually classify into low risk or high risk, and those with high risk, they actually start on either lenalidomide or lenalidomide with dexamethasone, and it shows that you can actually prolong the progression-free survival. So I personally will start treatment in those high-risk smoldering myeloma. Of course, whenever we want to start treatment in a patient who are asymptomatic, we should always talk to the patient, because whatever treatment is it, there's always side effect. So in the end, I think it's back to our patient-doctor discussion and how we're going to justify why treatment is indicated. As we know, myeloma is not curable. So whether to start early, late, there's always risk and benefit that we are going to talk about. So high-risk patient, yes, we should start treatment in smoldering myeloma.
Thank you, Dr. Wu. Second question is, can paraproteinemia occur in patients with normal serum globulin level?
I think Dr. Lim answered these questions, because you can have a kappa light chain myeloma, so you still can have a paraproteinemia in those who are non-secreting heavy chain, so you may not get a high globulin level. And there's also 1 to 3% with non-secretory myeloma, which is very difficult to diagnose. In patients with symptoms, sometimes we proceed with bone marrow and we noted it's actually a myeloma, but the SPP, SFLC, everything are normal. So these are non-secretory myeloma.
Yeah, okay. Yeah, I think the question probably should be rephrased as, can myeloma occur in patients with normal serum globulin level? So if your globulin is normal, likely your paraprotein also is not going to be very high, probably just a low dose. There's also a question from Dr. Chow, a very long one, I'll just read it. Does age influence our suspicion of multiple myeloma? I had a 40-plus male patient with end-stage renal failure referred to gastro for persistently raised ALP. workup was sent in view of concomitant raised Ig and anemia. Calcium level was normal. Skeletal survey, no lytic lesion seen. Should this patient be subjected to BMAT? Thank you.
Very difficult questions. Age don't really influence our suspicions. Eventually, in patient symptomatic, I will still proceed. We do say that those who are more than 60 years old, these are the common age group where myeloma happen, but we do see patients who are less than 40 years old, although the percentage is not high, around 10%, 10 to 15%. And I would say that if, let's say you think that the probability of having a myeloma is high, we can always proceed with the bone marrow because there's the ultimate. We do receive referral from our colleague who referred to us for raised Ig, anemia. They asking us, should we proceed? We always talk to the patient. Myeloma is never being excluded at this point. Of course, if they are not keen for marrow, we can wait for SPP, SFLC, but bear in mind, it takes 6 weeks to come back. We are not like other centers, which takes within a week that we can make decision based on our SPP, SFLC. So if the clinical suspicion is high, talk to the patient. If they are not that they are keen to proceed with a bone marrow, I don't see any resistance why we should not do a bone marrow for this patient.
I totally agree with Dr. Bu. I think the youngest here we have is about 40 or 40 plus years old. So if you're end-stage renal failure, even though patient may have diabetes and hypertension, but if there's a sudden deterioration in the renal function and you can't explain why, should always have a low threshold to proceed to do a bone marrow. Yeah, and very often we see a referral from outside is they depends on this serum protein electrophoresis or SFLC result to come back before they decide to do a bone marrow, and by that you already wasted about another 1 or 2 months and patient can actually progress from there. The earlier you make the diagnosis, the earlier you give the treatment, then it's probably to reverse the renal failure. Do we have any other? Oh, okay. There's another question from Dr. Caroline. Multiple myeloma not eligible for transplant with spinal involvement causing paraplegia. Started on treatment VTD. When will be the appropriate timing to refer auto for spinal surgery? Do we complete VTD first?
So I think this is good. I didn't touch about the spinal involvement in myeloma. So we have to know this, what type of spinal involvement. Is it a plasmacytoma that causing the paraplegia or due to the lytic causing fracture? If let's say this is a plasmacytoma, I think I will definitely refer to our oncology colleague for radiotherapy, because that will relieve the nerve, the spinal cord, and it may improve the neurological recovery for this group of patients. For spinal surgery is a very tricky question because it really depends on how good is the support from your spine team. Some spine surgeon may not want to move in as soon as possible because whenever they want to fix the bone, it may be a little bit difficult for them to fix it. So they might want us to give 1 or 2 cycles of treatment before they want to move in. But a lot of time, to be honest, I don't really see our spine surgeon go in and fix it because eventually after 1 or 2 cycles, which is 2 months later, there might be nothing for us to salvage anymore in terms of the neurological recovery. So I would think that it really depends on how good is your spine support, surgeon support. If they are very sportive and they are confident enough, they should go in as soon as possible. If let's say our ultimate aim is for the neurological recovery. If let's say it's a plasmacytoma, we should go for radiotherapy as soon as possible. I hope that answered.
And also, I think it's hard to say upfront that this patient definitely not eligible for transplant. Some patients who, despite have paraplegia, if they are not frail, we should still try to aim for a transplant because that provides the longest control of the disease. Yeah, like what Dr. Bu said, quite fortunate. Spinal surgeons sometimes may not be willing to go in, but do let them know that this VTD treatment is not like those intensive chemo. It doesn't really cause much myelosuppression. The infection risk is higher, but doesn't really cause much myelosuppression. So with supportive treatment, we can actually concurrently have this VTD treatment as well as the spinal surgery. So if it's indicated, it should not be delayed until 6 months later. Yeah. Any other questions?
Dr. Lim and Dr. Bu, just one question here. I actually want to type it out, but because I can't type it out, so I have to ask live. Because we have a few patients whereby sometimes, the elderly, about 60 to 70 60 to 70-year-old gentlemen coming in with very vague constitutional symptoms. So you notice that they are losing a lot of weight, they are anemic, but they do not have the classical criteria. So calcium is normal, probably just a bit of anemia, no renal impairment, your globulin level is normal, no bony involvement based on your X-ray. So because there is a suspicion of myeloma still nevertheless, because we know sometimes they do not have this, they do not need to fulfill the CREP criteria. So when we do a serum protein electrophoresis and the free light chain, sometimes the report comes out whereby the heavy chains are normal, but they do mention that the light chains are raised, but both kappa and lambda, but there is no monoclonal protein. How would your interpretation be for that?
That's a good question, Satik. Yeah, what happens is that the kappa lambda ratios in our normal body, there's a higher kappa compared to lambda. So it's around 3 to 2 or 2 to 1 at least. So it's not a typical 1 to 1 ratio. However, because of normal renal function, sometimes what happens is that the ratio, there's a ratio that we can refer to. But in patients with renal impairment, or possibly you have to look into the, if let's say she lost a lot of weight, but the creatinine may be within the normal range, but it's slightly higher for his body habitus, he may have some actually renal impact. So the kappa lambda may both raise, but as long as it's not a single light change that is higher compared to the other, it's not a monoclonal, so it is not a plasma cell dyscrasia for me. So you have to look into the other possibilities.
Yeah,
right. Yeah, great.
To add on to what Dr. Bu has mentioned, the ratio, the normal range for SFLC, the ratio for normal people is about 0.26 to 1.65. But for renal impairment, you can go up to about 3.1 like that. So when you have renal impairment, both also will be raised. So what Dr. Koh has mentioned is you see both the kappa and lambdas are raised, and you wonder whether this is really a multiple myeloma. Is that correct? And your M protein is not present.
Yeah, correct. So whether or not we should still pursue, along the lines of myeloma or not, because from the interpretation from the lab pathologists, they do mention that it could be, infection, inflammation. So whether or not, we haven't subjected the patient to a BMAT yet, but because with this report, it's, at a crossroads kind of thing.
If it's not really one very high and one very elevated compared to the other one, probably it's not along the line of multiple myeloma.
Yeah, totally agree.
Okay,
The two
thank you.
combination you can already pick up about 90 to 95% of the multiple myeloma already.
Great, thank you.
Thank you. So looks like everyone is understand very well of Dr. Bu's talk. I really have to say his talk is excellent and it's so good for the non-hematologists to know better this important topic. So let's hope that with this, when the patient come to you, you can detect it better, detect it earlier, and then do the necessary tests, and then make an early diagnosis, and then refer to a hematology center for early treatment of multiple myeloma. With that, we believe that the outcome of our multiple myeloma patient will improve in time. I pass it back to Dr. Koh. Thank you.
Thanks, Dr. Lim, and thank you, Dr. Bu, so much. I totally have to agree with Dr. Lim regarding the talk. I think to summarize, what we can gather is to actually raise the initial suspicion of myeloma. As we all know, I think we classically always go by the hypercalcemia, renal impairment, anemia, bony involvement, but I think we must bear in mind that there are a certain population of patients with light chain disease who do not fulfill this. So whenever you do not see this, it does not mean that it is not myeloma. I think that's number one. Number two, also regarding further investigations that we should actually send to actually complete the workup prior to referral to a hematologist. So thank you so much once again, Dr. Bu and Dr. Lim, for your time, and thank you to everyone in attendance. So next week, we have yet another common topic, which is the approach to hemolytic anemias. So we hope to see everyone